My name is Elizabeth Taylor Albert. I'm a general rheumatologist with USC's Division of Rheumatology. I see a variety of rheumatologic issues. I do have a special interest in lupus and autoimmune diseases and how they impact pregnancy. Today we're going to talk about something that doesn't especially affect women in their childbearing years. So again, I do treat other issues as well in rheumatology. Thank you, Dr. Alluri, and thank you, Betsy, for inviting me. So today we're going to discuss diffuse idiopathic skeletal hyperostosis. That's a mouthful, so we all usually use the acronym DISH. I have no financial disclosures. I hope by the end of this discussion today that you'll feel more comfortable diagnosing DISH and recognizing it on x-rays. Get updated on what we understand about pathophysiology and also some of the newer treatments that are being tried experimentally, but at least have some sense of a management strategy. This is something that all primary care providers see, people in pain management, certainly my orthopedic and neurosurgical colleagues deal with this on a daily basis. We see it, but as we talk about this, you'll also learn that anesthesiologists have to deal with the complications of it. Gastroenterologists might see them, pulmonologists, as our population ages, and we do such a good job helping people live longer. The problem is that then they also deal with the fact that they live longer, and the skeleton was not meant maybe to live into the 80s. This diagnosis of skeletal hyperostosis really is fairly new to modern medicine. It was in 1950 that Dr. Jacques Forestier and Jean Moreau-Chiarel described 200 patients with anterior ossification of the anterior longitudinal ligament and bridging, osteophytic bridging of the thoracic spine. And for a period of almost 20 years, the term used to describe this was senile ankylosing hyperostosis. It wasn't until 1975 in 1976 that Dr. Lloyd Resnick, with one of his fellows, really developed standardized criteria that lent themselves to both clinical diagnosis, but also to doing clinical and basic science research where we could all agree upon what diffuse idiopathic skeletal hyperostosis is. And so the term came into being. I know the orthopedic surgeons are familiar with Dr. Resnick. He's written the classic textbook on imaging, MSK imaging. He's in our neck of the woods in Southern California at UCSD, and has educated over 250 fellows in radiology, MSK, musculoskeletal imaging, and we're all very grateful to him for his contributions in medicine, not the least of which is organizing data into a coherent diagnostic criteria for DISH. So as you can read there, he and his fellow proposed that this really should be defined by the presence of that calcification and ossification along the anterior longitudinal ligament, and then seeing that bridging osteophytosis of at least 4 contiguous vertebral bodies. And described how these are not syndesmophytes, but actual osteophytes. And what you see in this disorder is maintenance of the discs. And if you in fact are your radiologist and you are seeing on your plain films degenerative disc disease changes as well, then you're not really dealing with DISH. This tends to spare the cartilaginous disc in the spine. And that's the second criteria, is that preservation of the disc height in the involved areas. additionally, what Dr. Resnick noted, which had not been part of the definition of this disorder, was that you could see some osteophytosis and of other joints, such as knees or hips, but you did not see any ankylosis of the sacroiliac joints. You don't see erosive changes there, nor on the marginal end plates of vertebral bodies, which is what you would expect to see in inflammatory back disease, ankylosing spondylitis, and or sacroiliitis. More recently, there is another diagnostic criteria that's been proposed by Utzinger, but this is basically used in clinical studies, not really part of the, if you would, diagnostic criteria for ICD-10 purposes and clinical management of patients. It weighs in heavily on the finding of hyperostosis elsewhere, such as in a major hip. And I'll show you images of what Utzinger is talking about. This is a CT from a 70-year-old male. And what I hope you can appreciate is anteriorly that there are osteophytes that move laterally, not vertically, not on the end plate of the vertebral body, such that you would see with ankylosing spondylitis, and that they eventually will bridge. There's also some appreciable calcification of the anterior longitudinal ligament. And in this three-dimensional reconstruction, you can appreciate that better. And it's oftentimes poetically described as this flowing, bridging osteophytosis and ossification of the anterior longitudinal ligament. And you do get a sense of this flowing pathology. Now, not just the anterior longitudinal spinal ligament, but also posterior can be involved. And this is just one slice where it shows it very nicely here as well. So the non-axial involvement that I mentioned earlier, these are two examples in the knee and the hip. I hope you can appreciate on this lateral view of the knee that there's both inferior and superior osteophytosis or ossification occurring on the patella, and then also on the tibial tuberosity here as well. It is, one could argue semantics that this could also be termed an enthesophyte. And so there is some debate in the literature whether you would term this an enthesophyte or an osteophyte, but it would be a calcified enthesophyte if you're going to call it that. And then on this patient's right hip, again, you can appreciate multiple places where, again, you're seeing this ossification of tendon and ligament attachment. It's more than just the fluffy degenerative change that you see with, say, run-of-the-mill osteoarthritis. So historically, this is something that's been around, interestingly, for quite some time. We know, even as long ago as 50,000 years ago, that a skeleton of a hominid shows signs of dish in the thoracic spine, and that once more expert evaluation and imaging was done of Ramses II's mummy, an Egyptian pharaoh, which initially it was proposed that he had ankylosing spondylitis, but subsequent evaluation really does show that he didn't have syndesmophytes and a bamboo spine, but what he had is dish involving his thoracic spine. There's also a very large group of skeletons that were evaluated by several paleo medical anthropologists in a graveyard in France that was published just a few years ago. And they found those skeletons that were dated from 450 to 1795 AD, now called CE. Again, findings of dish with some ossification of anterior and posterior longitudinal ligament and some of the bridging larger osteophytes. Now, patients themselves, some of these are autopsy studies, which show that, or if you do imaging studies, people getting a preoperative chest X-ray, which doesn't happen as much anymore as it used to, but a third of subjects may be asymptomatic. More often than not, you and I see the ones who have symptoms, right? And the majority do report back pain, but stiffness is a more common complaint even than back pain. And it affects their function, range of motion, including it's worse with bending. An important thing to keep in mind if you do find dish in a patient is that it does cause restriction in their pulmonary function. And that it does share in common with ankylosing spondylitis. So sometimes these patients also will report worsening dyspnea on exertia over time. And it's a real consideration. Occasionally it might be a manifestation that could affect decisions about surgical intervention or not. So what is going on? Basically, it's formation of new bone. And this new bone or bone bridge is mostly cortical bone, is not trabecular. And it moves from a vertebral body to a contiguous adjacent vertebral body. It's at the entheses or where tendons and ligaments attach. What's really interesting in this disorder is that it is always worse on the right side of the thoracic spine. And it's thought that the pulsation of the aorta plays a role in this because there are case reports of patients with situs inversus. Recall that means their heart is on the right, in the right side of the chest, not the left. Everything's the mirror image, who get dish mainly on the left side of the thoracic spine. In trying to understand, you know, at a cellular level what's going on, there is data more recently that patients can have elevated levels of growth hormone or insulin-like growth factor 1, which we know do stimulate osteoblasts and bone formation. These could be targets for treatment. But there right now is not, say, a biologic agent for them like we have with cytokines and other targets when we're treating inflammatory diseases like rheumatoid arthritis, or the oncologists have, say, with metastatic breast cancer. So we know that in these patients that new bone formation is being promoted. What's also been identified is that inhibition of new bone formation is not occurring, and that you'll actually see a decrease in an inhibitor protein, DKK1. I am not aware of any efforts right now to synthesize that as a potential therapeutic target, but you know, it would certainly be something to consider. So for our surgeons in the audience or people who are involved in taking care of patients, there are some complications that these patients are at higher risk for, which is sort of heterotopic ossification. Particularly, this is described after a total hip replacement, more difficulties healing and pain, and then this additional bone formation post-THA. Vertebral fractures tend to occur through the vertebral body. And in these, especially the ones with the thoracic spine involvement, they have a much higher incidence of instability and spinal cord injury, and so need to be viewed as more high risk. Definitely a patient that you'd want to hospitalize and do additional imaging and monitoring overnight, and or I don't want to tell you when and how to operate, but just to alert you that these are higher risk patients that you would maybe treat differently. And when you're taking a history from these patients, it's really not that they've done something intensely traumatic to themselves. It can occur with a very low energy impact fall from standing to the floor, not take much force at all. In the ER, so if we have any people in the audience who are the first ones to see these people, whether it's primary care or an emergency room physician, please keep in mind, if you see this on the patient's chart or even on the plain films findings for DISH, know that a CAT scan or MRI is going to be much more sensitive for detecting a fracture, and you wouldn't want to miss it. Also, for the patients who have cervical involvement, the anesthesiologists need to be aware. So if you're addressing someone's lumbar spine or knee or hip, these, just like with a rheumatoid arthritis patient, these patients need to have C-spine series, a complete series, so you know ahead of time if this is going to be a difficult intubation for the anesthesiologist. And this is just an example of how these anterior osteophytes, as they grow out, and enthesophytes in the neck, one of the presenting symptoms can be dysphagia as they displace the esophagus. So this is where, you know, sometimes these folks get referred to gastroenterology or ENT because of complaints about a fullness in their neck. I see this multiple times a year. So it's not an uncommon presentation. Unfortunately, we haven't had success yet in really impacting the natural history of this disease or getting it into remission like we do with so many other diseases we treat. You can perform glucocorticoid epidural type injections, which sometimes helps. Bisphosphonates, as recall that I said this is a problem where there's new bone formation and that process isn't inhibited. There are several trials with bisphosphonates which have not shown any better outcome than placebo, but we don't have any trials yet with something like Prolia, which could be promising. Everybody in this audience probably deals with chronic pain in their patients, so I don't need to tell you how to manage chronic pain, but always remember, if the patient's coming in and you have been treating their DISH symptoms, but they're complaining of more pain or in a different location, remember there are other causes for pain. Whether it's depression or metastatic lung cancer, keep in mind if it's not fitting the pattern that you've been treating the patient for, it doesn't hurt to re-X-ray or pursue other investigation. We do know that because this is more common in men and particularly associated with diabetes, hypertension, hyperlipidemia, that it's important that their primary care provider manage the metabolic syndrome. All too often, I'm sure many in the audience have been in the situation where you're managing someone's chronic pain or their spine disease, and you've sent them for physical therapy, and you filled out work forms or disability. They have to come back and see you to get their forms filled out again or whatever. They end up seeing you more often than their primary care doctor. Just give a nudge to the PCP that, in fact, controlling the diabetes and the hyperlipidemia and all does seem to have some impact or slow the progression in these patients. It's also important to think about fall risk. We already talked about the vertebral fractures. Physical therapy, especially ordering of fall risk reduction, is important, and then giving the patient pep talks afterwards about continuing to exercise. I found during the pandemic that more and more older folks that you think might not use the internet, in fact, have learned how to. They learned how to buy things off the internet and order groceries, or they have a grandchild or someone who can help them. And there are some really excellent online exercise classes, Tai Chi, which I would tell you from the rheumatoid arthritis literature is excellent for patients, better than yoga, and reduces falls, improves range of motion, conditioning, strength, reduces pain. So there are a lot of ways, if you work with the patient, brainstorm a little bit. I know it's hard in this short amount of time we have to visit with patients, but exercise options if they don't have access to an organized program close to home or a senior center or wellness center. This is my bibliography, and I think this is being recorded, and I sent the slides, so Betsy can certainly share that with you if you want to read more about DISH.